Good afternoon, all of you. How are you all? Good morning, Neelam. I'll just take a few more seconds and I'll start. Yes, good afternoon, all of you. Nice to see you all. All good, all good. Let us start, right? So, we have been talking about the first part. We covered few chapters and now we are left with the few we will be covering today. Okay, so we start with our first question here. So, we'll start with optics and squint and let's see how much we can revise here. So, what is the first question is, what is the angle subtended by the largest letter in the Snellen's chart on a person's eye who is reading it from a distance of 6 meters? You should be very clear about the concept of Snellen's box. What are the letters, what are the angles subtended? So, first we are going to quickly revise and then we will solve this question. Okay, so this is the Snellen's chart in front of you, all of you. I hope everybody is very clear that what is 6 by 6, 6 by 9, 6 by 12? Denominator is normal. We are comparing. A normal person can read this size letter at 12 meters, which your patient is only reading at 6 meters. A normal person can read this size at 18 meters. My patient is reading only at 6 meters. So, please be very clear here that it is the denominator which is normal, right? So, this is how we are depicting the visual acuity. Now, coming to a very important concept here, it's not that I just ask you to sit at 6 meters and start writing some letters and ask you, okay, tell me, can you read it? Is it a right way of taking the visual acuity? No. Why? Because the size of every letter on the Snellen's box has some scientific basis. And what is that scientific basis? Every letter subtends as a whole angle of, if you talk about letter E, or let me first draw for you here. So, every letter overall margin will subtend an angle of 1 minute and overall the letter will subtend an angle of into 5, that is 5 minutes. I have made it in a very simple way, very crude way to make you first understand this. We are saying that every letter on the Snellen's box, the margin subtends an angle of 1 minute and the whole letter 5 minutes. First question, where is the angle subtended? At the nodal point of the patient's eye. Okay, do you all remember what is a nodal point? A very quick revision here, that simple diagrams always help to learn, right? So, this is my way. So, just we will make a simple diagram like this to understand that the parallel light rays which are falling on the cornea, bent at the cornea, bent at the lens, are focused at a point first just behind the lens. So, this is the first focal point or the optical center of your eye, which is called the nodal point. Right. So, this is what is called nodal point of the eye, right. At this nodal point, we are saying every letter on the Snellen's box is subtending the angle of 5 minutes and 1 minute. How is it possible to believe? This is such a small letter, this is such a big letter. How are both the letters subtending the same angle at the nodal point? So, what is difference? What is the difference? What is different here is the distance. So, we are trying to tell you here that lowermost line, it is from 6 meter this will be subtended, but for letter E, this angle of 1 minute and 5 minutes, it is subtended at the distance of 60 meters. So, if you remember your physics, you must have learned this that the size of the image depends not only on the size of the object, but distance of the object from the lens, isn't it? So, apply that only. So, this is what we are saying, that it is the distance which is different. The letter E is going to subtend the same at 60 meters and the last line will subtend the same at 6 meters. Okay? If you are clear with this, another very important thing is why it is always into 5. So, how do you make a Snellen's box here? First is like this. Try to understand. So it is made up of 1, 2, 3, 4, 5 squares here, 1, 2, 3, 4, 5 here, 1, 2, 3, 4, 5 here. That is why the overall 1 is 1 minute and overall it is always 5 minutes. This is how we design the Snellen's letters, and first we make the square and we fit that letter into that. That is why we always learn that overall it is into 5, right? ठीक है? Then we talk about is the same, if you have understood what is the second here it is telling you is Landolt ring, so broken ring test for the illiterate. Again the concept will be the same. If we have understood this much basics of the Snellen's box, now you can very quickly answer this question in a very simple way. What is the question saying? The question is saying that what is the angle subtended by largest letter? Which was the largest letter? 6 by 60. So we already know that 60 meters, it subtends the angle of 5 minutes. It is asking you what about 6 meters, right? So this 1 minute, which is the subtended by the margin of the letter, we call it, what do you call that? Minimum angle of resolution, MER, okay? So when they ask you, for example, here they have asked you for 6 by 60 line. They are asking you what is the angle subtended at 6 meters by the 6 by 60 line. Yahi question hai. So how are you going to answer here? That minimum angle of resolution, right, is very simple method, reverse the fraction. Whatever visual acuity line they have asked you, just reverse the fraction. So I reverse it to 60 by 6. Okay? When I reverse it to 60 by 6, this becomes 10 minutes. ये हो गया minimum angle of resolution of 6 by 60 line at 6 meters. But overall what it will be? Always into 5. So our answer is 50 minutes. Hope it is very, very clear to you. Yes, many of you have answered correctly. Aman, it is not A. Now you know why it is not A. Pavan, it's all on the YouTube only. Yesterday only there was some technical issue. So we sat again at 4 o'clock in the evening. You can get it there itself. Okay, you can watch that. चलो ये हो गया, यहाँ तक समझ आ गया. This is how they can ask you. So you can solve one more question for me. Can you answer me what will be the angle subtended by a 6 by 12 line? All of you solve this. My next question here for you, or suppose they ask you what is the angle subtended by a 6 by 12 line at 6 meters. If this is what they want to ask you, अब आप इसमें कैसे करोगे? Tell me this. I am waiting for the answer. It is 6 by 12 line. So what will be the answer here? चलो. So again, what is the minimum angle of resolution? It will be 12 by 6, जो कि हो गया 2 minutes into 5. So when all of you are answering correct, the answer is 10 minutes. So we are now equipped and prepared how to answer these questions, right? Okay. There was once when I was drawing the diagram, I remembered a few more questions here. So we are going to try to focus on maximum questions on optics to start with. So all of you, can you tell me, they have asked you this, which is the most important factor to focus light rays on retina? Answer this question. I am saying most important factor to focus light rays on retina. फटाफट बता दो. What should you answer this? Most important factor to focus light rays on the retina. I'll wait for the answer. We can meantime move to the next question. Okay, so they will not ask you only cornea. Very good. So refraction is maximum in the cornea, and then the next best would be the lens where there is a refraction. Okay. Which surface of the cornea, anterior or posterior? Answer me this. ओके कंफ्यूज मेडिको योर नेम. देखो ऐसा नाम रखोगे तो हमेशा गलत आंसर निकलेगा. नाम थोड़ा सा पॉजिटिव रखो. इफ़ यू वांट टू चेंज योर नेम, मेक इट मोर पॉजिटिव. पॉजिटिविटी अट्रैक्ट्स पॉजिटिविटी, है ना. लॉ ऑफ अट्रैक्शन सीक्रेट बुक पढ़ी है. मोर यू थिंक पॉजिटिव, द मोर यू विल गेट पॉजिटिव. सो डोंट पुट योर नेम एज. सो यू सी आंसर इज ऑल्सो रॉन्ग. सो व्हाट इज द आंसर? इट इज द एंटीरियर सर्फेस ऑफ द कॉर्निया. ठीक है. Okay, so it is the anterior surface of the cornea. Okay, now very important question here, that why is the refraction more in the cornea? Tell me this. Why is the refraction more in the cornea? After this we'll go to the next question. Why is the refraction more in the cornea than in the lens? This is my next question. Anterior surface of cornea is the correct answer. Why? So what are the two factors where the refractive power of the cornea is more than that of the cornea, and which is the most important factor? Very good. It is the curvature. More the curvature, more the refractive power. Please remember. Okay? So we are going to talk about accommodation also shortly. So you will be very clear that why accommodation is not the correct answer. It's okay. When we make mistakes, we learn better because we know those no's. Right? So anterior surface of the cornea, and why most important is curvature. And what is the second? What is the second important factor? Curvature is one. What is the next? Next factor is difference of refractive index between air and water. This is aqueous here. So there is a difference of refractive index 1 and 1.33. This is the index in both. Hai na? So this is also responsible for more refraction and bending of light rays on the cornea. Okay, very good. So can you answer one more question to me based on this? Very interesting. This was your NEET PG question only. So the question they had asked you that if you are swimming underwater, why is the vision less? I think majority of you should know swimming, right? That is very important thing. It's life saving. So anyway, or you can modulate the question if you can't relate with the question, that if you wash your face and you are splashing water in the eyes, you don't see clearly. But the question was, if you're swimming underwater, why is the vision less in underwater? Why can't you see clearly? So it's the interesting why, because now your media instead of air and water becomes water and water. So when the media becomes water and water, less bending. So what is happening? Loss of refraction. Because of this loss of refraction, हमें कम दिखाई देता है पानी के अंदर. ठीक है? This is the reason we are not able to see clearly underwater. ठीक है? Okay. So that was about Snellen's. We come to the next question. Now we are here for accommodation. With a near point of 10 centimeters, okay, a hypermetrope of 5 diopters has to exercise accommodation of. Can we solve this? All of you? How to solve this? With a near point of, so first basic formula, दो चीजें याद रखनी है, you will solve any question like this. What are the two things? First, basic physics you have to remember that any power is inverse of focal length in meters. This thing should be clear to you, right? Secondly, you should know this, that when you talk about accommodation, right, what is the range of accommodation? Means nearest how much I can see clearly, farthest how much I can see clearly. This distance is my range of accommodation where I have to exert the accommodation, isn't it? So the range of accommodation is depicted as, if it is depicted as range is equal to, so what will be the range? Far point minus near point, है ना? So remotum is far, proximum is near. Now we are talking about power. When you talk about power of accommodation, matlab the amplitude of accommodation, this is what is your question. This is range, the distance, this is the amplitude, the power. This is depicted as capital A is equal to, all of you, power or accommodation will be maximum exerted when? Near point or far point? बताओ, maximum accommodation कब हो रहा है? Near में कि far में? चलो, tell me this quickly. It is in the nearmost पे or farthermost? I'll wait for the answer. Quick. Yes, near, right? Not far. Accommodation will be maximum, Dr. Chaudhary. It is more going to be when you exert more at the near, na? है ना? दूर से जब पास देखते हैं, then only you should have a more power. So accommodation is exerted more. Therefore, now the range amplitude of accommodation will become capital P, which is the power at near point, and minus capital R, which is power at the far point. हो गया? This is so simple. If I remember this formula and if I know this, I can solve this question. चलो solve करते हैं. So how to solve this question? Here what you have to see. We are asking near point how much accommodation exercise. That means value of A is being asked. What is the power at the near point? Near point is 10 centimeters. What will be the power? समझ आ गया? So it will be inverse of focal length but in meters. So what is the power? 10 diopters. So this is the value of P minus, now he is a hypermetrope of 5 diopters. So far point pe the power is already given 5. Pay attention, this is the trick. If this patient was a myope, I would have just said minus 5. but he is hypermetropia. Far point in hypermetropia is always behind the retina. Okay, behind the eye. Therefore, we always depict the power at the far point as minus. If I depict it as minus, this becomes minus 5. Okay, so 10 minus minus 5, algebra lagao, it becomes 15 diopters. So your answer is B. Is it okay? Ishu, now is the voice okay? I'll repeat it if the voice had broken. I'm just saying that what is the power at the near minus what is the power at the far. You have to find that will be the amplitude of your accommodation. So power at near, again if the near point is 10 centimeters, inverse of focal length in meters, therefore now the power is 10 diopters. Then you go to hypermetropia hai, so you will always depict the power at the far point as minus as it goes behind the eye. Therefore it becomes minus 5, so it is 15. And anyway you have to know this. So what are you trying to do? You are trying to change centimeters into meters, na? Sayantani, very sweet name, very musical, huh? So that is why, na, meters mein, it has to be in meters. That is why inverse of focal length in meters. That is the reason. Okay, so if you have understood this, I think it's absolutely clear now. And accommodation, because some of you were having confusion, what is the basics of your accommodation? I think very important. Yesterday also I talked about the second sight of old age, if you remember. What are the steps of accommodation? So please, no confusion. Many of you answered me that accommodation is maximum when we are at the far. So I am repeating this concept again to you. When you are looking from far to near, दूर से पास देखने पे, there are 3 things happening in your eye. One is convergence, other is meiosis, third is accommodation. What are the steps of accommodation? First is your contraction of ciliary muscles, okay, and then what next is happening is your relaxation of zonules. Number 2, some of you don't understand this also. You have to understand this is a section. Actually, the ciliary muscles are all around. So when they contract, these zonules, they relax. When that will relax, it is going to lead to mild increase in curvature of the lens. Okay? So when I am looking from far to near, these things are happening. Meiosis, convergence and accommodation. What is the third step of accommodation? Increase in curvature of the lens. Mild increase in the curvature of lens. More the curvature, more is the power. And therefore, we get more power that we need to see the near. Okay? So that is what is accommodation. 1, 2, 3. So now you know maximum accommodation means we are most near point pe maximum accommodation. Okay. We come to the next question now. So coming to the next, on what is the type of astigmatism in the patient using glasses of, this is the prescription. First of all, let me tell you something. Whenever you get a prescription like this, first change it into a retinoscopic reading and then comment on the type of astigmatism. Okay? So before I do that, they have asked you about compound, hypermetropic, myopic. This is what we have written here. So with the rule, against the rule, है ना? तो अब आप quickly पहले revise करते हैं. What are the different types of astigmatisms? So astigmatism, you know, is when there is a difference of power between 2 principal axes. That is what is called astigmatism. If I am writing here +2, this is not astigmatism. But if I write here +2, +1, now this is astigmatism. Correct? And what did we learn? Any astigmatism we can classify. First way of classifying can be either one axis is plus, another is no number. It is emetropic. Then you call it simple hypermetropic astigmatism. If one is, it can be any axis. Suppose this time this axis is emetropic, other axis is on minus, that is myopia. Then you will say simple myopic. If both are plus but of different numbers, this is compound hypermetropic. If both are minus, this is compound myopic. And if there is 1 plus, 1 minus, this is what is called mixed astigmatism. Clear it? What is the second way? What is with the rule and against the rule? Very simple. Normally with the weight of our lids, there can be some mild 0.25 type of difference which is considered normal. So difference of what? What I am trying to say, with the pressure of the lids, the vertical is generally more curved than horizontal. If you get a very minimal finding, like it is considered physiological. अब अगर उसी direction में in the same way the astigmatism is happening, means the curvature of vertical is more than horizontal, that is called with the rule. It is still following the rule, therefore we call it with the rule astigmatism. ठीक है? So with the rule means that the power is more in this. With the rule means something like it is more curved. This is more power in the vertical. This is your with the rule. And now when there is more power in horizontal than vertical, this is what is called against the rule, right? So this becomes against the rule. Got it? What is with the rule and what is against the rule? Okay, there are two more ways of classifying astigmatism. Let us complete it before I go to this question. Another way is regular and irregular. You have to know that when you say regular, it means suppose I write here +2, I write here +3. So +2 is everywhere in 90 degree, it is same. This is what is regular astigmatism. But suppose cornea is so irregular that even in a single axis there is a variation. +1, 0, +3, something like this. So now this is what is irregular astigmatism. Even in a single axis when there is a variation, then this is irregular astigmatism. Okay? Got it? Where do you learn this irregular astigmatism, all of you? We will answer keratoconus. We learn it in keratoconus. Then we talk about, or there can be any corneal opacities which can cause irregularity of the cornea. Ab fourth kya tha? How do we classify in the fourth way? Sorry. Fourth way is, okay, this one, normally the principal axes are at 90 and 180 and it is 90 degree angle between them. So if this is the case, this is what is called, this is also called regular. Okay? Now focus, listen to me. When the two axes is like this, these two principal axes at 90 and 180, this is regular. Now the angle between the two is still 90 degree, but they are not at 90 and 180. अब इसको हम क्या बुलाते हैं? This is called oblique astigmatism. So the angle is still 90 between them, but it is not at 90 and 180. This is called oblique astigmatism. Now come back to this. If the angle between the two is now less, okay, now this is what is called bi-oblique astigmatism. Now practically, what is most important and the questions will be asked are on these two. You should be very clear about these two classifications. Chalo, if we know this now, we can come back and solve a few questions. First we will solve this one. 4 diopter spherical plus 3 diopter cylindrical. So what I will do, I will make 2 lines here. 4 diopter spherical means 4 is everywhere. Okay. So this is let us first focus on, you can just read it again and see the video again, you will be clear, otherwise you can ask the questions one on one. Okay, Dr. Chaudhary? Yeah. So now we will first focus on this one, maybe if I have time I will repeat that. Okay. तो अब देखो ये रेटिनोस्कोपी के 2 लाइन बनाओ. Now 4 diopter spherical मतलब here also +4 spherical means number is all around. अब क्या है? +3 cylinder at 180. Everybody knows this. Axis is mentioned opposite in prescription. If I am saying 180 means power has to be at 90. Please write it somewhere on your study table. Axis is mentioned opposite. So if I say +3 diopter cylinder at 180, it means +3 I will put at 90. Okay? So if I put +3 at 90, what is the retinoscopic reading of this whole thing is, it comes to +7 +4. Okay, all of you. Everybody knows both plus means it is compound hypermetropic. So that is simple. Is it with the rule or against the rule? So this is the trick. Can you tell me here what you all have answered? What have you answered here? Nobody has answered correctly. What is plus? What is hypermetropia? Less power. What is myopia? More power. We denote it with minus because we are using a concave lens and we are trying to say that kitna mujhe kam karna pada, how much I have to decrease to focus on the retina. That's why myopia is indicated as plus. How much I have to increase to focus on retina? Hypermetropia is indicated as, myopia is indicated as minus, and how much I have to increase to focus on retina? So hypermetropia is indicated as plus, isn't it? So जब हम plus कह रहे हैं, it is hypermetropia, it is less power. So more I am going in plus means it is lesser, na? What is the normal refractive power of your eye? 60 diopters. See, I am making it very simple for you. Focus here. 60 diopters, ठीक है? अगर यहाँ पे लिखा होता, if it is saying here, this is 0 and this is -1, do you know what it means? This is 60 diopters, E-metropic eye, we will take the power as 60 diopters. -1 means more power, so this becomes 60 plus 1. And when we denote with plus, we mean minus. So here it is 60 minus 7, this is 60 minus 4. Now is it clear to you all? Now is it simple? So do you realize where is the power less? Power is less in the vertical. So it is actually against the rule astigmatism. So that is the trick. Be very, very careful in this. And you will be absolutely clear if you understand by this way. 0 is 60. If it is minus, you will add. If it is plus, you will subtract. ठीक है? Okay. चलो, what you do is, you just tell me a few of them, just quickly answer me this, just quickly answer me this. Before I go to the next, let me see whether you could understand or not. I am going to ask you the astigmatism in the terms of with the rule or against the rule. All of you, example number 1, first of all. You will just put the question number and then answer, okay? This is question number 1, question number 2, question number 3, question number 4. We will answer these 4 questions. Okay, so tell me what is the type of astigmatism here? With the rule or against the rule? Come on. For question number 2, what it is? For 3, what it is? And for 4, what it is? I really expect some answers here. I am ready to spend 2-3 minutes waiting for you. It's okay. Quickly answer me for all. For all. I need answers for all. 1 ka kya, 2 ka, 3, 4. Let's see. If you don't say 1 and 2, it is so confusing. Okay, 1 is with the rule. I am getting the answer 1 as with the rule. Very good. What is, Ranu, why do we say 1 against the rule? -3 means 60 plus 3, na? And this is 60 plus 2. So is it with the rule or against the rule? Vertical is more means it is with the rule. ठीक है? Very good. Okay, what is plus 3 and minus 2? Plus 2. This is 2 is against the rule. Very good. So this is against the rule. What about number 3? Very good. Ravi Shankar has answered so nicely. Everyone, number 3, everyone is answering very nicely, to be honest. But I got all the 4 answers from him, that is why. So this is your with the rule. Very good. What about the last one? What is the answer of which type of astigmatism is number 4? All of you quickly. Quickly. Number 4 batao. Shifana, number 4 is against the rule. What about the rest of you? What about number 4? Chalo. We have to move to the next. Yes, number 4 is not astigmatism. All of you. Right? Some of you have answered correctly, yeah? Same power in both. It is not astigmatism. So don't be alert what you are answering. Good. Now let's come to the next question. And one of you had requested me कि मुझे last page समझ नहीं आया. So I feel very discomfort if you don't understand. So I think it was Dr. Chaudhary. So focus here, Dr. Chaudhary. The third way of classifying astigmatism is if in the single axis you have the same power, right? This is a regular, but there can be a situation that even in a single axis there is a variation. Now this is called irregular astigmatism, which we see in keratoconus. Third and the last was when the two principal axes are at 90 degree, and this is what is regular. This is normally seen in majority of us, okay, where the principal axis is at 90 and 180, angle between it is 90 degree. Second, I said the angle is still 90 degree between them, but they are not at 90 and 180, then it becomes oblique. And when the angle is less than 90, now this is bi-oblique. I hope it was helpful. We come to the next question. So what is the, come to the next question, focus here now. What is the retinal magnification of the eye with a refractive error of -8 when viewed from the direct ophthalmoscope? What is, how do you, first of all, direct ophthalmoscope, how do we calculate the magnification? You should know the formula first. So the formula here is power upon 4. Okay. Now when you say power upon 4, what is the power in the eye? It is the refractive error of -8. Just now we discussed, when we say -8, it means what? It means what? 60 plus 8. So you have to just do 68 upon 4. Okay? So 17 times is the answer, right? Yes, so 68 upon 4 kar do. Yes, so this was about your this. Okay, now we will also learn about one more thing. How do you calculate the magnification of indirect ophthalmoscope? All of you, you should also know this. The power for the indirect magnification is power of eye upon power of lens. Okay, power of eye you will decide according to whatever refractive error is mentioned upon power of lens. And power of lens kya hota hai? That is, the power of lens would be your majority of the, it is mentioned in the question only, and majority of the times it is 20 diopters. Very good. Yes, Ravi Shankar. So this is how we will calculate the magnification of indirect ophthalmoscope. Okay? Okay. Then we come to few more questions, and these have been a repeated questions of your exam, and they are still asking it. So a quick revision here, some points for direct and indirect ophthalmoscope. Number 1, they ask you what is the magnification normally. So normally we see this is 15 times, right? Magnifies well, and this is only around 0.3 or 5, ya to 3 times or 5 times, okay, whatever. Second they will ask you what is the type of image formed in direct. Direct, what forms is virtual and erect, and indirect is real and inverted. Okay, optics thoda sa you have to revise. Then third, they will ask you about the visual field. At one time, if I am looking through the direct ophthalmoscope, how much I can see? It is 2 disc diameter. What is 2 disc diameter? 2 into 1.5 mm. And for indirect, it will be, for indirect, 8 dd. Okay, that means 8 into 1.5 mm, I can see it one go. So common sense, that is why, because magnification is also led natural. If you are looking through a magnifying glass, you generally see that is magnified but field is less. That is the principle of any instrument, right? So when the magnification is more, field has to be less. When field is more, magnification is less. So this is what you have written here. Now that means direct is used to see the central retina and indirect will be used to see the peripheral retina, right? All our exam questions asked separately. This is a Q, this is a Q, this is a Q, this is a Q. The only thing that has still not been asked is this. Everything has been asked repeatedly. Next question. What is distant direct ophthalmoscopy when the same direct is used at a distance? What is that called? What is the distance direct ophthalmoscopy is done at what distance? We will answer 25 centimeters. Generally, what do we see? We see the media of eye, isn't it? Yeah, we see the media of the eye. Achha, you all have answered correctly about 20 diopter lens in indirect ophthalmoscope, but one more point just to keep you informed. Indirect can be variable lenses from plus 13 to 30. Anything is possible, but yes, what we learn most commonly is 20. Okay? Pata hona chahiye, so I am telling you this. Okay, then we talk about next thing. Once you know this, very recently only in your NEET PG, they had asked you one question that while you are examining through a direct ophthalmoscope, which eye of the patient, which eye of the examiner, and what do you ask the patient where to look at? So if you are my patient, I have to see your right eye. I will use my right eye, okay? So this is what is, remember, right eye to right eye, and I will ask you to look straight and not in my instrument, because if you look in the light, the pupil constricts. Okay? Isliye you will look straight. So this is another question of your exam, that it is the same eye, right eye ka right eye, examiner and patient, and the patient should look straight, not in the light, not in light. Okay? This is another important question. And then another thing they have asked you was, if for indirect ophthalmoscope, where is the image formed? So generally, comfortably we do it with the patient lying down, we are at the head end, right? There is a headband, the light is coming out, we hold the lens. Hai na? Where is the image formed? Between the examiner and the lens, in the air. Okay? So remember, the image is formed here, between the lens and the examiner. You remember that? You note it down, please. So this was your question. Right eye ka right eye. Okay, and the patient should look straight and not in the light. Yeah, so these were some questions around these two instruments. We come to the next question now. On Worth 4 dot test, what is the patient sees 3 green dots? What is the diagnosis? Good afternoon, Harsha. So answer this. Worth 4 dot test पढ़ते हैं पहले, है ना? Worth 4 dot test. There is a box. Just listen to me in my simple way. एक box है with different color lights, red, 2 green, 1 red, 1 white. कितना बोला? 2 green, 1 red, 1 white. Patient is wearing red green glasses. I can see only red from my right eye, or maybe white part I can see. Only if it is green, I can see with my left eye, only green. Clear hai? Now how to do it? Once you will just ask the patient, but test yahi hai that you have to ask the patient. First listen. You will just ask the patient, what are you able to see? How much red, how much green? So that is why this question. The patient is saying, I can see 3 green dots. Let us see. So this is the inference I should understand. This is the box with the 4 lights. Red green glass, if there is problem in his left, he will see this as red and this also as red, white also as red. So he will see 2 reds. But if there is a problem in his right eye, to red nahi dikhega, only 3 greens, right? That means there is a right eye suppression. And if he sees more than 4, it is diplopia. Is it simple? Red green glass, R for R, right eye red, left eye green. ठीक है? Red green, R for R, red color in right eye. So once you know this, 2 अगर red बोलता है, that why 2 and 3 are different? Because initially the number of dots that you have to know is green dots are 2 here and only 1 red. That is why he sees 2 red, then it is left suppression. If he sees 3 green, it is the right eye suppression. Clear hai na, all of you? Yes, very good. Nicely answered. So we will answer right eye suppression. This is the answer. Okay. Chalo, we come to the next question here. So what is the wavelength of the laser used in the above procedure? What is this procedure? First answer me this. I will wait for the answer. What is this procedure all about? What are you looking at? Come on, answer me this. Batao. No, Dibham. I didn't ask the answer. My question here is that what is the procedure you are looking at? Which laser surgery is happening here? What is happening here? Is my question. Don't answer A, B, C, D. That I will discuss with you. Can you quickly tell me what is actually this all about? Okay, if you say femtosecond laser, Devapam, then femtosecond, it is not NDR, please. So this is femtosecond laser. What is the procedure? Is it a cataract surgery you are looking at? Why are we writing this? Lens FLACS, why did we write that as the answer? Is it a cataract surgery or the femto is being used for some other procedure here in this slide? No, it is not cataract surgery. Oh my God. Can't you see the piece of this cornea being taken out here? देखो ध्यान से. This is your small incision lenticule extraction. It's a refractive surgery which is called SMILE procedure. ठीक है? This is a SMILE procedure which is done by femto laser. Therefore, we all know that the wavelength of femto laser is 1054. So this is the answer. But what is happening? You know what we do here? In LASIK, what do you do? LASIK is done by excimer laser. You know this? Which excimer? Argon fluoride. What is the wavelength? 193. Okay, this was your exam question, so you should know this. Okay, so in LASIK, what do? We are focusing directly on the, in LASIK what we do, we first run a microkeratome and raise a flap. And once we have raised a flap of the cornea, now you are focusing the laser on the stroma, modulating according to the need, and then put the flap back. but there were many flap related problems as well. So this is a newer technique where I don't have to raise the flap, directly focus the femtolaser on the stroma, cut a piece of it, uska ek tukda kaat liya according to how I want the corneal curvature to be, and after a small incision I am taking out that piece. This is the lenticule, this is the piece which I am taking out, the stromal piece. Okay, so this is a SMILE procedure. Got it? So answer here is 1054, and this is another question. And what about 1064? This is the wavelength of Nd:YAG. You should know this as well. 1064 is wavelength of Nd:YAG. What is the use of Nd:YAG? So many of you have answered wrongly. Nd:YAG. Nd:YAG is a cutting laser. It can make hole. Okay. So where do you want to make hole in the eye? Definitely not on the cornea. So why do you answer Nd:YAG? I can either want to make a hole when there is a opacification of the posterior capsule. So that is why we do it in a posterior capsule opacification. है ना? Think with me. Do I want this Nd:YAG to be on the cornea? No. Do I want it on the retina? No, baba. It will create a hole. So where do I want it? I want it at the posterior capsule. And the second place where I want it is at the peripheral iris. So the two indications of Nd:YAG can be peripheral iridotomy or posterior capsulotomy. समझ आया? So this is what you have to answer. So these are the indications of Nd:YAG. The wavelength is very important. Nd:YAG can be asked, high potential to be asked, 1064 nm. This is the posterior capsular opacification that I have just shown you. Got it? So this is the indication of Nd:YAG, where it is a cutting laser which makes a hole. Right? Yeah. Okay. And what is the other wavelength written here? 514. Argon. Okay. This is the wavelength of argon. What is argon? Argon is a photocoagulative laser. Right? Argon is actually a photocoagulative laser. Argon, what is the other one? Diode. And double frequency Nd:YAG also becomes photocoagulative. Don't get confused. When you say double frequency Nd:YAG, it means wavelength is half. Okay, that means 1064 ka half, so 532 nm. This becomes photocoagulative. So photocoagulative lasers can be this one, it can be diode, or it can be argon. Okay? So it's a photocoagulative, Rohan. So all the indications of photocoagulative lasers, you can use a double frequency Nd:YAG. Where do you use photocoagulative lasers? What are the primary use? One is on the retina, pan-retinal photocoagulation. So generally photocoagulative lasers are used on the retina, or I can use in the trabecular meshwork for trabeculoplasty. Okay? So these are the indications for use of photocoagulative lasers. Take it, Rohan? Right? Yeah. Okay, we come to the next question here. Identify the correct statement. Now before I go to the, let us quickly read the statement, then we will be able to understand how to answer. Increase in hypertropia on opposite gaze. So first of all, there is hypertropia. It's a fourth nerve palsy or not. यही देखना है. पहले आप इसको देखो. Hypertropia तो दो वजह से हो सकती है ना. Inferior rectus is gone or superior oblique is gone. Let us see here. What are, in this I can see that there is left eye hypertropia. ठीक है? When this patient is looking towards the same side, the hypertropia is not increasing. But when he looks on the opposite side, it becomes more. Now we come to the head tilt part. Left eye, when he is opposite, on the right side when there is a head, this is the right side, okay? Right head tilt में आपको क्या मिल रहा है? Eyes are straight. Same side head tilt as you see here. Left eye on wall, left side head tilt. Hypertropia increases. Okay? So what did you learn here? Hypertropia is increasing on same side head tilt and opposite side gaze. Opposite gaze है ये और ये same gaze है. Trabeculectomy is a surgical procedure where you remove the trabecular meshwork and create a fistula between the anterior chamber and subconjunctival space. Trabeculoplasty term is used when you are applying the photocoagulative lasers on the trabecular meshwork. Okay? Clear? So what is this altogether? What is the diagnosis? You have to keep this in mind. fourth nerve palsy, whenever the superior oblique palsy, what do you see? Listen to me first, listen to me. We will explain this in a more simple way so that it's easier for you. First of all, your basics have to be very clear regarding action of muscles. And what, चलो पहले वही revise करते हैं, फिर ये question solve आसानी से हो जाए. We will just very quickly learn how to learn the action of muscles. So when you talk about action of extraocular muscles, do we not know that we have 6 muscles, right? And there are 6 actions: elevation, depression. Take my right eye towards the nose, adduction, away from the nose, abduction. And then inward, when your 12 o'clock is tilted inwards, this is intorsion, and when it is rotated outward, it is extorsion. 6 movements, 6 muscles. How to learn it? So we will learn in my simple way, divide it into horizontal muscles and vertical muscles. So these 6 muscles are horizontal and vertical. No, it's not same actually. Shri, it is not that same. Let me come to this and then I'll explain you. So horizontal muscles, lateral rectus, medial rectus. Let's revise it even if you know. Only one action, this is abduction, medial rectus, this is adduction. Correct? Now we come to vertical. For vertical, 2 mnemonics which makes life easy: is and rad. Is rad. Okay? Is says superiors are all entorters. Just learn this. And then rad says that recti are adductors. Rad says that recti are adductors. Okay? Once we know this, superiors are entorters, recti are adductors. Now make a chart. Make a chart. For vertical muscles, superior rectus, inferior rectus, superior oblique, inferior oblique. Pay attention, you will learn it thoroughly here. Just pay attention. Primary action, secondary action, tertiary. How to learn this? Just most important action, lesser important, lesser important. Okay, अभी के लिए ये समझ लो. Otherwise, of course, इसमें और technicality में if you are going, then primary action is more when it is an abducted eye. We will just learn like this only. Most important, little lesser, little less. Now learn with me in this way that abduction and adduction mainly are the work of horizontal muscles. So because they are the work of horizontal muscles, for vertical muscles they are always tertiary. Okay, so tertiary means for recti are adductors. I will write here adduction, adduction. For oblique I will write abduction, abduction. One row is complete. Okay, now we take one by one muscle. First is superior rectus. What is the primary action? Everyone remembers this. Superior rectus elevates. So its life is easy, elevation. Superiors are entorters. Secondary action will become intorsion. Done. Now we talk about inferior rectus, just the opposite, depression and extorsion. Oblique's primary action is always torsional. Okay? So what do we write here? We will write here superior oblique intorsion is the primary action and inferior oblique extorsion. Oblique है, उल्टा काम करेगा. We all know superior depresses, inferior elevates. Therefore, we will write here depression and here it is elevation. Okay? So this is how we learn the action of muscles. Once you are clear with the action of muscles, what is very important to understand? When the eye is abducted, that's why primary action is considered in the abducted eye. When the eye is outward deviated, then the main action of elevation and depression is of recti. When the eye is inward deviated, main action of elevation and depression is of obliques. If you understand this, then only you can understand about superior oblique palsy or Park 3-step test and whatever. This basic should be absolutely clear. Okay? So you have to understand this, that actually, okay, even that has a basis. We cannot go too much in detail about it, but yes, with the visual axis and recti, they form an angle of 23 degree. Now when the eye is abducted, it comes in line with the line of the muscles. Therefore, now the action of elevation and depression is totally of recti muscles. So 23 degree abduction, you don't have to remember the degree, just remember in abducted eye, it is the these recti which are working as elevators and depression. Adducted position, it is the main action of obliques. Many of you have a confusion, ma'am, ऐसे कैसे है, फिर तो वो तो abductor है, वो adduction. This is for single action, right? We are saying it is already outward deviated eye. Once it is already outward deviated, ऐसे समझो ना, outward deviated, obliques will also help in outward deviation, isn't it? So then the action of elevation and depression mainly is of recti. और अगर 51 डिग्री adducted position पे है, now it is in line with the oblique muscles. यही reason है when the visual axis comes in line with the oblique muscles, now action of elevation depression mainly becomes that of obliques. So can we write this please? If you write this, you will never make a mistake and you will be able to solve everything very nicely. So make a box and write here, please all of you. Put a box and write this: in an outward deviated eye, okay, deviated eye, that is abducted eye में action of elevation and depression is of recti, and vice versa. You want to write the vice versa, write it for yourself. When you understand this, you will understand this also. If it is a superior oblique palsy. Now this is very, very difficult to comment how many questions or not. So there is you may get 1 or 2 questions, you may not get from it. That's why I always suggest that we cannot pick up chapters. Okay, I will leave this chapter. You have to know everything, right? It is very unpredictable how the questions are asked. In between they had started asking you more from optics and squint, then it's little less, but of course optics was asked even this year. So you never know, right? You have to be well equipped with every surprise, right? So anyway, this is not a surprise, they have asked you this many times. So we have to know what they have already asked you, because majority of the questions are in and around repeated only. So all the questions that I am discussing here, maybe since yesterday, are the ones which in and around have been asked, so that we try to crack maximum, right? So that's why it has been planned this way. Hope for the best that we are lucky enough to cover everything. Yeah. Chalo, can we now explain this to you all? Is it easy now? So if it is a superior oblique palsy, you understand that there is hypertropia because of that. When the eye is in the opposite gaze, this eye will be adducted. It needs the action of superior oblique, which is not there, therefore hypertropia increases. Got it? Why are you getting increase of hypertropia on the same side head tilt? Anyone? I'll show you the slide again here. See, this one this is again the same question I'm asking on this slide. This child has a hypertropia. Can you see that left eye? Now, when the head is tilted on the same side, the hypertropia increases. And when the head is tilted on opposite side, it almost is same. No, it is. So that is why this is the compensatory head posture. So we have to understand why the hypertropia is increasing on same side head tilt. Okay, listen here. What is happening? When you suppose this was the hypertropic eye, right? When there is a same side head tilt, eye needs, whenever you tilt the head on that side, that eye needs to intort to look straight. Okay? Now, when you same side head tilt, this was hypertropic, the eye has to intort to look straight. What are the intorters? Superiors are intorters. Lekin, superior oblique is already paralyzed, there is hypertropia. Then what happens? Too much responsibility on superior rectus to intort. So when superior rectus is overworked, what is the primary action of superior rectus? Elevation. So you will see that hypertropia increases. This is the reason why same side head tilt is increasing hypertropia. We call it Bilchowski's sign. Okay, this is what is called Bilchowski's sign. Yaad rahega? So when you solve this question, it becomes absolutely easy now. There is increase in hypertropia on opposite gaze. Okay. Is there increase in hypertropia on same side gaze? No, it is on opposite gaze. Increase in hypertropia on same side head. So I identify correct statements hona chahiye tha. So increase of hypertropia on the same side head tilt or opposite side, it is same side head tilt. So I want you to write this in a box. I did not change the question style. And it has been made by me only, but I did not change because I wanted for you to know all these 2 points. We are anyway revising. So these are the 2 correct statements. So kaise yaad karoge? What is the gist we have been talking about? Write down. In SO palsy, hypertropia increases on same side head tilt and opposite gaze. Correct? Okay. Come to the next question here. Which of the following statement is wrong for the above figure? So, this is the figure where you can see this patient with a right eye esotropia. Eso is convergent, tropia is squint. So, okay, so there is a right esotropia or convergent squint. So, which muscle is gone? Lateral rectus is gone. So, which nerve palsy? We are looking at 6th nerve palsy, right? So, this is 6th nerve palsy. Now, let us see what they are asking. It is a right esotropia due to 6th nerve palsy. This is a correct statement. It causes horizontal diplopia. Yes, horizontal muscle will lead to horizontal diplopia. You all know, no? What is horizontal? Double is diplopia. When the two image true and false are like this is horizontal, this is vertical, and if you tilt, this is torsional. Okay, then it causes cross diplopia. Horizontal squint, esotropia. Is it crossed or uncrossed? Uncrossed. So, this is the wrong statement. And it leads to face turn towards the right side. Yes, face is always turned towards the side of action of paralyzed muscle. Okay. So, diplopia is maximum in the action of paralyzed muscle. Compensatory head posture will be face turn towards that side to avoid that. Okay. So, this is correct. So, how to answer on diplopia? Very quickly. Diplopia, जैसे astigmatism पढ़ा था, just remember this. What are the questions they have asked you on diplopia? One way of classifying diplopia is it can be horizontal, vertical or torsional. That is one way. What is the second way? Second way of, yes, very good. Shri, yeah, answered correctly. So, second way of knowing what is the type of diplopia is it can be uniocular or binocular. Okay? Either it is uniocular or binocular. Question, which is the most common cause of uniocular? Make a Q, write down subluxation of lens. Other causes could be like polychoria, or you have learnt about intumescent or incipient cataract causing polyopias. That can also be considered as under uniocular diplopia. But the question was about subluxation of lens. Binocular, paralytic squint most commonly, right? Apart from paralytic squint, most commonly we see here, we can also get in restrictive conditions like, I am not writing, if you want you can write down blowout fractures, thyroid eye disease, TED. Okay? Third way of classifying. The third way of classifying diplopia we will say is, can I rub this? Crossed or uncrossed. Pehle samajh lo, what is crossed and what is uncrossed? So, if suppose this pen is the false image, this is the true image. And it is this side of the eye which is paralyzed muscle, there is a squint on the right side. In this patient also the squint is on the right eye. So, if the false image is towards the squinted side, this is uncrossed diplopia. When the false image is opposite to the squinted side, this is called crossed diplopia. Okay? Same side uncrossed, opposite side crossed. You should be very, very clear about that. And how to remember? Now, we will remember in my simple way. किसमें क्या मिलता है? Very simple. Make a cross and after the cross make an arrow. What do you see? When you have crossed it, it's a cross arrow is showing divergence. So, in divergent squint, you are going to get a cross diplopia. So, when I say divergent squint, we are talking about medial rectus palsy, third nerve palsy. Okay, and vice versa banao. Let's make the vice versa. Convergence, how do we show convergence is like this? If we show convergence like this, is there any crossing? No. So, uncrossed diplopia in convergent squint. That is lateral, because then only you can answer the questions on Maddox rod, right? Yeah. Chalo, we come to the next question on that only. Because Maddox rod is something your source of phobia for you all, so I selected the question. Let us discuss this one for all. Is it stuck? Let me see. Is it okay now? Great. Now, ठीक है. A 40 years old patient with esophoria, Okay, first of all, you have to know phoreas are latent squints, which means when you look at the patient, you feel okay. The eyes are looking straight. When you cover one eye by cover uncover test, you see okay, there is some break of fusional reflex and then we can catch hold of the squint. That is called phorea or latent squint. Maddox rod, Maddox wing, these are tests to check the phoreas which has not been able to in a usual uncover test. Then you want to go for this test. What do you do in a Maddox rod, Maddox wing? So before I answer this, we should be able to summarize here. So we revise here. So Maddox rod is this. What is this? These are just cylindrical lenses, okay, plano-convex, series of them. When I am putting it horizontally like this, actually this patient will see from his right eye. So he is made to sit in front of a light bulb. So normally he is seeing the light bulb. When you put this Maddox rod from his right eye, now he sees it as a line of light. Because you have put it horizontally, the line of light is vertical. If you will put vertical, the line of light becomes horizontal. Anyway, what about the left eye? He is seeing the same spot of light. ठीक है? अब ध्यान से सोचो. What is the test? Put the Maddox rod, ask the patient what he can see. If everything is normal, this is what he will say. Orthophoria means he will say the line is crossing the spot of light. If he says the line is right to the spot of light which is left, right eye mein line hai, line is right, spot of, you understand what we have actually done. If one eye we are seeing a line and one eye spot, you have created artificial diplopia so that he can see two images by two different eyes, so that you are able to catch hold of any phorea. Okay, this is what is called differential image test, creating two different images in front of the eye. So जब आपने artificial diplopia create कर दिया, what is now happening? From the right eye he says मुझे right में ये दिख रहा है, left he says it is there. So if right he is saying is, I think this is it correct? No, wait, let me first explain in this way, don't get confused. If from the right eye he says that this is the situation, he will say okay, so the line is to the right of the spot of light. This is his observation. Suppose this is the right side of the patient, this is the left. He says the line is on the right and the spot is on the left. This is your uncrossed diplopia, and in uncrossed diplopia what you get is esophoria. But if he says no, the line is to the left and the spot is to the right. So whatever the patient is seeing and explaining to you is what is, you have to read it on the paper. So if this is on the left and this is on the right, now you know line should be from the right eye. It is seen as a left side and this is seen as the right side. So it's a cross diplopia, and if it's a cross diplopia, it is exophoria. I am not showing this because I think there is something wrong with this. I did not realize. So we will understand this way. So now, okay, this slide was, there is another way of learning that in exo it is crossed, X is crossed. This is another way you can remember. Okay. Then what is the question here? Question says this patient has esophoria, tested with a Maddox rod, placed in the right eye, will see the spot of light where? So Maddox rod is in the right eye, it is an esophoria. So right eye will be, right side में line मिलेगी, left side में spot होगा. So what will you say? The spot of light is left to the line of light. So many of you have answered correctly. Yes. So it will be on the paper. Whatever the patient is seeing is on the paper, and this is what you have to answer based on that. You don't have to reverse it. Please don't do that. Okay? Yeah. Right. So that was about this. And what is this, all of you? Very quickly, this is what is Maddox wing. What is the difference? Maddox rod is mainly done for far vision at 6 meters, and at 33 centimeters this is Maddox wing. Again we are differentiating the two eyes. Right eye will see only arrows, left eye sees only numbers. Okay? So right eye only arrows and left eye only numbers. So you just have to ask the patient, for example, we are seeing the horizontal, white arrow is pointing where? If this white arrow points somewhere here, it is going towards same side, so it is a esophoria. If this is pointing, this white arrow is somewhere here, now this is exophoria, it becomes crossed. Similarly, your red arrow, if the red arrow is down, that means it is opposite, crossed, right? So if he says some numbers which are down here in the red arrow, these right eye is up. So it becomes right hyperphoria. And if he says the red arrow on the upper numbers, this means right eye is down because arrows are from the right eye. If right eye is down, can we also say left eye is up? If right is down, left is up. That is why you see written as left hyperphoria. Because it's a protocol to mention the eye which is up, right? So this is the way we are seeing the Maddox wing. Okay. Ayush, it is possible from April, I think we have told. Okay, then we talk about this one. I think this everybody can answer now. What is contralateral synergist of right inferior rectus? What is the quickest way? First, do you all understand contralateral synergist means yoke muscles? We are talking about yoke muscles, right? And yoke muscles, very simple. So when you talk about, we are talking about two eyes working together. So what are the two muscles working in our right horizontal gaze and left? We have discussed yesterday also. So ये हो गया right. If this is the right gaze of the patient, this is the left. ऐसे दिखा रहे हैं. So right lateral rectus, left medial rectus, left lateral rectus, right medial rectus. Now what will be the muscle when I am involved when I am looking like this? First, forget about the figure. Look at me first. So if I am looking like this, do you realize right side is dextro, left side is levo? So if we say looking like this, right, this, your right eye is outward deviated, but your left eye is inward deviated. So outward deviated recti will work, inward deviated oblique will work. Okay? So if it is elevation, what are the muscles which elevate? Superior rectus, inferior oblique. So what are the muscles? Right superior rectus, left inferior oblique. See, this is what is written here. Similarly, in depression, so whenever they ask you, no, you just have to do like this. Suppose I ask you, tell me the muscles involved in levo depression. Can you answer me this, please? What are the muscles involved in levo depression? No, don't get confused, Dr. Shri. Okay, that's a good question. You all answer this first and I will just take that. So if the Maddox rod was on the left side, this means left eye is now seeing the line, right eye is now seeing the spot. This is the only difference. Now when you ask the patient, if it is uncrossed diplopia, the line, it will become, the findings will be just opposite to what you have just learned. If he says the line is left, the spot is right, this is uncrossed. If he says line is right, this is left, this is crossed now. है ना, crossed and crossed बदल गया ना. If suppose we had learned कि right eye में line है, left eye में dot है, correct? In that case, this finding, this above finding is not uncrossed. This becomes crossed na. Right eye should have line. So for this finding is crossed, and this finding is uncrossed. If this is the situation, and if this is the situation, this is it. Now is it clear? देखो. Tell me, Dr. Shri. अतुल क्या नहीं समझ आया? थोड़ा पढ़ना पड़ेगा. कौन सा नहीं समझ में आया? डेक्स्ट्रो लीवर लीवर डिप्रेशन कुछ भी नहीं है उसमें, तो ये ठीक है. श्री बता दो जरा. गॉट इट? वेरी गुड. अच्छा ये देखो, लीवर डिप्रेशन इस को दो में भी डिवाइड करो अतुल. लीवो इज लेफ्ट. डिप्रेशन में कौन कौन से मसल्स डिप्रेस करती है? इंफीरियर रेक्टस करती है, सुपीरियर ऑब्लिक करती है. लीवो मतलब दिस साइड, व्हाट विच आई इज आउटवर्ड? लेफ्ट आई. आउटवर्ड आई में रेक्टाई वर्क्स. सो लेफ्ट इंफीरियर रेक्टस एंड राइट सुपीरियर ऑब्लिक. सिंपल था. Tell me, now is it okay, Atul? Yeah. So this is how we learn, and this is, so now when you have to quickly answer for right inferior rectus, now I am giving you a tip. Please pay attention. Agar concept now you have understood. Now listen to the tip. Just turn every letter opposite. Don't waste time. Right inferior rectus means left. Right ka left. Inferior, superior, recti, oblique. So it becomes left, superior, oblique. If you answer just superior oblique, Neelam, it is wrong, na? Right and left is very important, na? So is it right superior oblique or left superior oblique? That is very important. So you have to say that. Okay. So this is left superior oblique. Just turn every letter opposite. ठीक है? चलो next पढ़ते हैं. Okay, so this was the concept on this. We come to the next few questions here. Yes, Neelam, very nice. Atul, now it is okay? Haan, good. So most common ocular manifestation of COVID-19. दो main ocular manifestation. This was your NEET PG question. I picked up as such to discuss something here. Two things you will remember. One is conjunctivitis. One is central retinal artery occlusion. Most common, of course, is conjunctivitis. It is a viral infection. It has to be follicular conjunctivitis. Okay? CRAO is also one of the manifestation of COVID, serious manifestation of COVID. And mucormycosis is due to the steroids that had been taken without thinking, which caused this opportunist infection, that is mucormycosis. Right? You all know mucor, it is mainly present everywhere. We inhale the spores, but we don't generally get infected. But it is when the immunity is down that you can get infected by this fungus. Right. So if we are clear with this, we will see few slides here. What is this? These are follicles, but these are the trachoma follicles, okay, sago grain like follicles of trachoma. Just remember this. It can be asked, this is an important slide. Right? We all remember trachoma. Trachoma is a chronic conjunctivitis caused by Chlamydia trachomatis. What is the strain? You should know A, B, BA and C. B, BA and C. This is asked. They also ask you what does the strain D2K causes. You will answer adult inclusion conjunctivitis, which is also called swimming pool conjunctivitis. This is, I'll now, these are factual questions, so slow, slightly faster. So be focused. Yes, sabudana, sago grain. Okay, so this is your adult inclusion conjunctivitis, which is swimming pool. और किससे होता है? Can anyone answer this? Guys, swimming pool conjunctivitis happens by which other organism? Or, okay, which other virus? One is chlamydia, this is one thing, and which virus? Adenovirus, okay? Please remember, this also causes, so swimming pool term is an overlapping term for both D2K and for adenovirus. Right. And when we are discussing trachoma, we should not forget safe strategy. I think they have become very fond of this topic. Every time they are asking INI-CET and NEET PG. So you all know it is surgery, antibiotics, facial hygiene, environmental cleanliness. Yaad hai na? So when you say, I am writing here. So safe strategy is very important. Again asked, which surgery? It is primarily trichiasis surgery, or which will involve entropion surgery as well, but when both are given we will mark trichiasis, okay. So preferably we will mark trichiasis, otherwise entropion is also correct. Then antibiotics, which antibiotics? We all should know, either oral azithromycin or topical tetracycline. Which is preferred? Again tetracycline to only available in ointment form, na? Right? Therefore it is better to give oral azithro. 2 tablets you eat and you are over, right? And tetracycline is ointment 1%. They have asked you this, how much percent of ointment? Can you tell me which other drug is only available in an ointment form apart from this? Which is only available in the ointment form? So ointment form, one is your tetracycline, and the another drug which has only in ointment form is acyclovir eye ointment. Okay? Acyclovir eye ointment for the viral keratitis, how much you give? 3%. Remember that. You can note down, I am not noting down here. Facial hygiene we know, environmental cleanliness we know. Next question around safe is, what is the criteria to start safe? How will I decide, okay, in this area I should start safe, here I should not? So criteria is that the prevalence of trachoma follicles should be more than 10%. Okay, the prevalence of trachoma follicles, this is FIST O classification ka 1 class, okay, stage 1. So you should say TF of more than 10% in that area, then only we start safe. And if suppose it is 5 to 10%, then can I rub this? Don't come messy. If it is 5 to 10%, then we will follow 5 to 10% में बोलते हैं, we only follow F and E, and if it is less than 5%, nothing is done. Doesn't mean you don't follow F and E, but under this program nothing is done. Okay, yeah, nice. Atropine, Ravi Shankar, is again 1%. You are asking atropine ointment, 1%. So atropine is a choice of cycloplegic for children within less than equal to 8 years of age, ideally. But school going children, if you give atropine, it will be a lot of hassle, right? Next we talk about is, come to this one. We all know this is not follicle, this is papilla, and this is what is cobblestone appearance. This is exam question. Where do you get it? We are talking about vernal keratoconjunctivitis, right? Okay, what are the other questions on VKC, all of you? No follicular reaction, number 1 question. Number 2, of course, these are mainly seen in male children. It's an exogenous allergy, right? What else you have to revise here? That vernal keratoconjunctivitis is a type 1 hypersensitivity reaction, right? Type 1 hypersensitivity reaction. So we generally see eosinophils on the, that is Horner-Trunta spots, right? We know this about eosinophils and Horner-Trunta spots. If you want, these are some basic questions. You must all be knowing this. These are easier topics. I just wanted to first take the heavy ones, which we are almost over with. So this is a, when there is a papillae on the upper palpebral, or papillae can be on the upper limbus. These dots are Horner-Trunta's dots, which are seen in the center, right? You can make this very quickly. So this is what is cobblestone appearance. These are Horner-Trunta spots. Always diagrams, diagrams, diagrams. Your copy should be full of diagrams and labeling. It will be quick revision, easy revision, picture memory, everything is going to help, okay. So you will see I generally make diagrams and list the findings, which is always very helpful, okay. So Horner-Trunta spots are nothing but, they have asked you, you will say eosinophils. They are nothing but eosinophils, right. And of course, one more question here on this topic was ropey discharge. Yes, Ankit, very nice. It is ropey discharge. Yes, Vishwa, it is seen mainly in the summers. It is not, it is called, actually it's one place it was written both spring and summer. So I thought, is it still a misnomer or not? So different sources say differently, but generally it is seen in summers, right? Yeah. Okay, what was the next option here written was, you will have a quick look at CRAO. We all know about CRAO. Yesterday we had discussed our retina part, but this one. So this is what is cherry red spot, right? So you should know cherry red spot, which is a feature of CR. What are the other causes of, and of course you can see the retinal edema in CRAO that you are seeing. So why do you see cherry red spot, all of you? Hota kya hai? Edema is everywhere, but the very center of fovea doesn't have all those layers where there are blood vessels. Yesterday we learned the layers of the retina as well, right? So it has only with fovea and foveola. Fovea has 6 layers, foveola has only 5 layers. So those layers are not there and it's an avascular zone. There is no blood supply, right? So no leakage, no blood vessel, no leakage. So no edema out there. Therefore, background redness of choroid is seen as cherry red spot. Actually, this is an area where there is no edema. Got it? Because of this typical anatomical structure. This is seen as cherry red spot. That is why you get cherry red in Berlin's edema, which is called commotio retini. You get it in this one, CRAO. Where else do you get cherry red spot? All the depositions. तो ये जो deposit हम ऐसे याद करते हैं ना, cherry red spot के causes Berlin's edema, then CRAO and depositions. Depositions, just to make it simple for you all. So all these depositions. Okay, Ramanand, I just see one question of yours. Giant papillary conjunctivitis is seen after too much use of contact lens. Keep in mind the size of the papilla are larger. It is not restricted to small male children. It is not a different type of reaction on the papillary reaction on the conjunctiva, which is very different from vernal. Okay, Ramanand? ठीक है, आप बस giant papillary conjunctivitis has been a question. So very good you asked. It is after contact lens use. बस इतना याद करो. Acha, yes. So Gauchers में we do get cherry red spot. Your Ophthal book says so. So we will learn like that. Even in Gauchers we see Tay-Sachs, Gauchers, everything we Niemann Pick. There's nothing like most common, Ankit. Don't learn about most common. But yes, we do have cherry red spot. क्यों? Basic समझो. All these depositions are again on ganglion cell layer, which is not present in the very center of fovea, and this is the reason of getting a cherry red spot. ठीक है? Yeah. Okay. One more question on before I move from central retinal artery occlusion. One more question, answer me, that a patient has got central retinal artery occlusion but he is not blind. Why? Answer me all of you. Quickly answer, then we go to the next one. My question is, a patient of central retinal artery occlusion can still see. Why? How? Anyone? I'll wait for this one. बताओ 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 जल्दी से. Very nice. Debapam, very nice. So dual blood supply, which is the other. So 14% of world population, make this diagram, you will never forget, have got a dual blood supply at their macula. One is your central retinal artery and the second one is your cilioretinal artery. So if this patient has got cilioretinal artery, what happens? The central vision and the field around it will be left behind. And it's very small field around the central vision. Sabko pata hai, this is what is called tubular vision. What happened? This is, if this is the small visual field, this is what is tunnel vision or tubular vision. We talked about tunnel vision yesterday also, right? Keyhole vision in posterior cerebral artery occlusion. So tunnel or tubular vision. Remember this. Cilioretinal artery, not PCA, not MCA. So PCA, MCA has been discussed yesterday. I don't know how to now call you. So Dark Night 08, baap re baap. So all of you, so you can just watch the video and we have discussed everything about what is keyhole visual field defect and keyhole vision. Yeah. So what happened, Shri? Why O? So this is cilioretinal, tunnel vision or tubular. I have another question for you all. What are the drugs which can cause tunnel vision? This has been asked in the exam. Please remember, one is quinine and second one you can say vigabatrin. Vigabatrin was your exam question. It can cause constriction of the visual field. Okay? Yeah. Chalo, we can come to the next slide. This is what is your black fungus. Black fungus, this is nothing but necrosis of the tissue because it is very it is invading the blood vessels and there is necrosis of the tissue. So we are looking at mucormycosis, right? Okay. And we have talked about this is most common fungus causing orbital cellulitis. Ankit, what do you want to ask? Ocular massage is done for treatment of CRAO as a sudden drop of the for aiming to suddenly drop the intraocular pressure so that the emboli, because majority of the time it is the emboli which causes CRAO. And second cause of CRAO is mucormycosis, that was also asked, keep in mind. CRAO ka na main cause is embolism, so heart disease patients, but also it can occur due to mucormycosis. So this had been asked. Treatment, yes, you want a sudden lowering of the intraocular pressure, start with IV acetazolamide, go for ocular massage and carbogen inhalation for vasodilation or sometimes sublingual isosorbate for vasodilation. ठीक है? यही पूछ रहे थे? Yes, for mucormycosis we have to go for amphotericin B. Yes, intravitreal भी allowed होता है, but if it is there, but in the orbital में भी है, तो you have to go for IV amphotericin B. Correct. Yes, Sharon, that is fine. Correct. Yeah. Rhizopus is another cause. Mucor and rhizopus both are causes, Gauri. Yeah. Chalo, we come to the next question, all of you. Let's change our focus now. Secondary signs of xerophthalmia. Everybody knows xerophthalmia is vitamin A deficiency. Quick revision of WHO grading of xerophthalmia. SXN is nyctalopia. This is night blindness, right? We will discuss the questions after this. Then comes 1AB. A is conjunctival xerosis and B is bitot, B for B, bitot spot. Done. What is X2? This is corneal xerosis. Corneal xerosis. Right. Then X3, A and B. What is A? This is keratomalacia or melting of the cornea. Right. Of less than 1/3 of the cornea, and B means more than 1/3. XS is corneal scarring, and what is XF? This is xerophthalmic fundus. It is xerophthalmic fundus. What is xerophthalmic fundus? White spotted fundus. White spotted fundus. Done? Okay, pehla question hai, what are the primary and secondary signs? This was your question. Please remember, when we say secondary signs, it means it can be seen in other conditions as well. So, which are the secondary signs? Very simple: accent, excess, XF. These are the secondary signs. You know other causes of nyctalopia, other causes of scarring of the cornea, other causes of white dotted fundus. So, what will be the answer here? Xerophthalmic fundus. Okay, this is, so which is not secondary signs of xerophthalmia except, so this is except hoga, all in except, because this is also secondary, this is secondary, this is secondary. So, answer is this, Bitot spot. Rest all three are secondary signs. Okay? Second question, which is the earliest sign or which is the earliest feature of vitamin A deficiency? This was your exam question. You will answer earliest feature as nyctalopia. Third question, Bitot spot is most commonly seen where? See, this is what is Bitot spot. So, Bitot spot is more commonly, you will answer first temporally. It can occur both sides, but first it is temporally. It's drying now. So, generally what happens? Tear is draining on the medial side, nasal side. So, it is more drying or temporally. And this is what is keratomalacia, which is melting of the cornea. Nyctalopia is night blindness, yes. Come to the next question. The next question says identify the incorrect statement. We all know we are looking at the pterygium, all of you, right? Almost, this is again a very favorite topic for your exams. Yes, so identify the correct statement. Elastotic degeneration of the cornea, yes. Okay, it's always elastotic degeneration of cornea, you should say conjunctiva, it should not be cornea. So, first of all this has to be, so in the conjunctiva, and it is the same for pingicula. So, I think we have two incorrect statements here. It should be conjunctiva. Most common site, yes, please remember for pterygium it is nasal. It is caused by UVA rays or B rays. So, this is an error. So, A and C are wrong. A and C are wrong. This is UVB rays. Please remember UVB. And of course, choice of treatment. What is perfect surgery, all of you? Do you know this? So, we all understand that a simple excision causes recurrence in pterygium. How to prevent recurrence? There are two methods. Either we give mitomycin C or we go for autografting. Which is better? We answer it is autografting is better. In autografting, what you are doing? Make the diagram. What we are doing is, we are generally taking out, we are just cutting the, suppose this is the pterygium, right. So, you are removing this pterygium and this is now the bare sclera. If I simply leave the bare sclera, this is called bare sclera technique, but in that case the recurrence is very high. So, from the same eye, I cut a block of conjunctiva, I dissect further to include the limbal stem cells. If this is the X side and Y side of the graft, now I have to be just careful that after resecting the pterygium, I am putting the graft like this so that my limbal stem cells are transferred. So, this should be the X and this should be the Y. We have to be careful about this one. This is what is autografting. Now, if I do everything over enthusiastically, that means resecting a much larger area, so that if so much area is now bare sclera, I have to put a larger graft. And this is what is called perfect surgery. Perfect stands for pterygium extended resection followed by extended conjunctival transplantation. Okay, so this is what is perfect surgery. We see that if we are doing this, our recurrence is almost 0.01%. So, it is almost 0%, almost 0, not exact 0. So, recurrence becomes almost 0. Right. So, this is perfect surgery, pterygium extended resection followed by extended conjunctival transplantation. Okay? Okay. One more point. Can you tell me what are the effect of UVB in the eye apart? One is pterygium, what is the other? Can you answer this? This question is for you all. What is the other effect? Batao, batao, batao. Fatafat. What is the other effect? Have you all heard about snow blindness? What is snow blindness? When you're going in the snow in the heights, the UVB rays will reflect from the snow and injure your eye, leading to corneal epithelial erosion. This is what is snow blindness, also called photophthalmia. Yes, cataract is not a wrong answer. That is one of the contributory factors. So I will write it this also. I intended to discuss this. So snow blindness is occurring due to UVB rays. It causes corneal epithelial erosion. And how to manage this? You just give antibiotic ointment and pad and bandage it. And what is the injury by infrared ray known as? That is not photophthalmia, that is photoretinitis. So this happens when you directly look at the solar eclipse with your unaided eye. You can damage the macula. It causes macular burn. So this is serious, leading to macular scar. So it becomes permanent loss. Okay. So infrared rays is causing photoretinitis. Yes, Anubhav, that area, the conjunctiva will regenerate by itself. We don't have to worry about that. Okay. Okay, then we come to the next question here. Mizo-Nakamura phenomenon can be seen in the following conditions. Do you know what is Mizo's phenomenon? This was your exam question, so we started teaching you all. So Mizo's phenomenon, Mizo-Nakamura phenomenon, usme kya hota hai? The patient has night blindness. Listen, he is not able to see at night. When the same patient is made to sit 1 hour in dark, now, and when you, of course, when this patient is examined, the fundus is pale, it is not red, it is more yellowish. Now when you make this patient to sit 1 hour in the dark, he starts seeing, that means no night blindness, and the fundus also looks normal. This is what is called Mizo's phenomenon. Okay? It is a feature of Oguchi's disease. Oguchi's disease is nothing but a type of congenital stationary blindness. Okay, so this is the answer. It's a type of congenital stationary, means it will not progress night blindness. One is Oguchi's disease, second type is the one which is written here, that is fundus albi punctatus. These are all types of congenital stationary night blindness, right. So if you look here, this is what is Oguchi's disease, where the fundus is very pale. Okay, yes, I remember why I kept these pages was to discuss with you what are the causes of nyctalopia, all of you. So very quickly, this is vitamin A deficiency, number 1. Then don't forget retinitis pigmentosa, right? High myopia. What is high myopia? Any myopia of more than 6 is high myopia. And what is the next after this? Late stage of primary open angle glaucoma. Late stage of primary open angle glaucoma. And of course, if you talk about some fundus causes, we will talk about congenital stationary night blindness, which I just mentioned. जिसमें आएगा fundus albi punctatus. Fundus मतलब mainly you are looking at the retina picture. Albi is white, punctatus means dots, white dots. So it is actually night blindness with white dotted fundus. Okay, so this is night blindness with white dotted fundus. And what is the next one? After this, this next is Oguchi's disease. Okay, I will give 2 more in the list. Choroideremia, which is a choroidal dystrophy, and your gyrate atrophy. Gyrate atrophy. So these are the causes of night blindness. And what about day blindness? It is called hemarlopia. Hemarlopia is day blindness. And what are the causes here? Just remember, any central opacity can lead to day blindness. That means central corneal opacity, right? Another will be central lenticular opacity and congenital absence of what? Cones or rods? Cones. You know? Congenital absence of cones. Okay, let's see. The prevalence of blindness in India, what will you answer? 0.36%. So at present what we answer is this. So everybody, earlier it was learnt as 1%, the earlier data, now it is 0.36%. Just remember this. Okay? Okay, how do you define blindness? Let us learn this, a few questions around it. So a WHO definition says it is best corrected visual acuity in better eye. Don't forget to say this. Of less than 3/60. or visual field of less than 10 degrees in better eye. This is what is blindness. Chalo, NPC bhi kya kehta hai? 2017 they have changed the definition, and National Program for Control of Blindness also says less than 3/60. But instead of saying best corrected visual acuity, we just say best available visual acuity of in the better eye of less than 3/60, visual or visual field of less than 10 degrees in the better eye. Everything rest is same. Okay. Best presenting visual acuity or best available visual acuity, this is how you have to learn. Rest is same. ठीक है? Okay. Why, what sense it makes, I don't know, but anyway, I personally don't feel very convinced with this, but it should be best corrected only, isn't it? You should see with the specs whether the patient is able to see or not. Right, but we have to answer like this only. Now, a few questions around this. Quickly answer me, which is the most common cause of blindness in India? You will answer cataract. Okay, if I ask you most common cause of preventable blindness in India. So, blindness can be prevented, no? Though cataract cannot, but blindness can be. So, first answer is cataract. If this is not given, then you answer trachoma. Yes, very good. Keep answering. Okay, tell me this one next. What is the most common cause of childhood blindness in India? Childhood blindness, we will answer vitamin A deficiency. Then what is the most common cause of? Second most, they have asked you this also. Second most common cause of blindness. This time they have asked you NEET PG as well. You will answer refractive errors. Then what is the most common cause of ocular morbidity in India? Again you will answer refractive errors. Let's come out of India. What is the most common cause of, I am not writing, you can write most common cause of blindness in the world. Again you should answer cataract. If they ask you most common cause of blindness in developed countries, now you will answer first glaucoma, second option ARMD, age related macular degeneration. Okay? Chalo. We come to the next here. The question is about Fuchs heterochromic cyclitis, all are true except. Okay. Is it usually unilateral? Yes, that is why you are getting difference of iris color and heterochromia iridis. So, it has to be unilateral. Is the involved eye lighter in color? Yes, so this is correct. Associated with posterior synechia. So, this is the wrong because there is no posterior synechia. And what is Amsler sign? Do you all remember? When you take out aqueous, there is a, when you go for aqueous tapping, what you see is bleeding on the opposite side. This is what is Amsler sign. Okay, we will first make a diagram, note down all the features and then I will show you the slide. So, Fuchs heterochromic cyclitis, make the diagram all of you. We will learn in my style. We will give the heading Fuchs heterochromic cyclitis. Okay, first of all, of course, it is unilateral, there is heterochromia iridis, note it down. And very, very important, it is an atypical, generally primarily anterior, though sometimes posterior will be involved, but we will learn atypical anterior uveitis. At your level, this is what we will learn. So, atypical anterior uveitis. What is atypical? What are the features we have to learn here? On the diagram, please, stellate KPs. Number 1, stellate KPs, keratic precipitates. HI, heterochromia iridis. No posterior synechia. Iris atrophy की वजह से also there is no posterior, there are atrophic patches in the iris. Okay? Done? Okay. And sometimes there can be exposed blood vessels in the angle. So, these blood vessels, because of these blood vessels that you see, it could be new blood vessels, all the exposed ones. What happens here when you see it in the angle, when you are doing a paracentesis, there is bleeding. This is what is called Amsler's sign. This is about your Fuchs heterochromic cyclitis. And again, because this patient will not have all those features of an anterior uveitis like redness, pain, photophobia, that is why we are calling it atypical. Hence, hardly any role of steroids and cycloplegics. We just manage. What is the management? Manage the complications. What can be the complications? Very simple, complicated cataract, mainly it can be associated with posterior subcapsular cataracts and secondary glaucoma. Okay? So, these can be the complications. So, let us have a look here. So this is a heterochromia iridis. Of course, this is the lighter eye, involved eye with even cataract can be seen here. Okay, this one. You appreciate? Yeah. Then we talk about this. These are what are called stellate KPs, star-shaped KPs. These are stellate KPs. This is the bleeding on paracentesis, which can be even seen on gonioscopy or on the slit lamp. This is what is called Amsler's sign. Okay? Yeah. We come to the next one, immune recovery IRU after heart. What is heart? Highly active antiretroviral therapy. है ना? So highly active antiretroviral therapy you are giving in a patient of HIV, right? And he has, what is the most common complication that is happening to him? Kyunki immunity is getting better now, again there are inflammations. So actually he again starts having uveitis. This is what is called immune recovery uveitis. And an immune recovery uveitis, just remember, could be anterior, it could be intermediate, posterior, everything. Okay? So, but if I have to pick up one and answer which is the mainly it is involving, actually यहाँ पे you will answer, because we have an option of all of the above, we will answer all of them. But primarily how does a patient of IRU present is mainly vitritis, intermediate uveitis, and vitritis generally becomes the first presentation. Okay, it's a non-granulomatous posterior vitritis by which the patient, posterior uveitis by which the patient, not intermediate, sorry, you will learn posterior. Non-granulomatous posterior uveitis may be the first presentation, but it can involve all three parts of the uvea. It's a debatable question, that's why I have put it here. Take care. It can involve all parts of the uvea. We will not say it is only anterior uveitis. Rather, primarily it is presenting with vitritis first. I think now it's clear. Okay, so that was your immune recovery. A few questions here, all of you. Which is the most common? The two questions, answer me on HIV. Most common ocular feature of HIV and most common, next question, most common opportunist infection of HIV. So I hope you know, most common ocular feature is nothing but microangiopathy. Pathology of small blood vessels, that is microangiopathy. Microangiopathy is characterized by, you will see hemorrhages in the retina, you will see microaneurysms, and we discussed microaneurysms in diabetic retinopathy yesterday, you remember. So microaneurysms and cotton wool spots, again we talked yesterday, these are soft exudate. There was a question, all three were given an option. If that is so, we answer cotton wool spots. We will pick up this, right? Opportunist, we all know it is CMV retinitis. Let's have a look. So these are the multiple cotton wool spots. This is a case of HIV microangiopathy. Okay? I can see few hemorrhages, but primarily look at the cotton wool spots. It's a serious condition, more hypoxia, more damage of the axons. Okay, what is this? This is a CMV retinitis showing sauce and cheese retinopathy. So this is a CMV retinitis, yeah, sauce and cheese retinopathy. What about pizza pie? You know, in the latest edition and in detail when you go into this about the findings of the CMV retinitis, it has the mottled appearance sometimes that is seen in the CMV infection has been specified as mozzarella pie pizza appearance. So they have really particularly described that as well. Anyway, so but sauce and cheese retinopathy or whatever pizza, whatever you want to learn. हाँ डॉक्टर श्री वही वाला क्वेश्चन था जिसमें हमने माइक्रो एन्यूरिज्म्स के पिक्चर्स भी देखे थे, बहुत सारे इमेज में देखा था ना, the images that we saw. Okay, we come to this one. Again, a very important question for you all. I'm picking up all those conditions which have been asked earlier as well. This is Posner-Schlossman syndrome. What is the other name of Posner-Schlossman? We call it glaucomatocyclitic crisis. Pay attention first. We will read the question together. Glaucomatocyclitic crisis. ठीक है? Or it is also called hypertensive uveitis. वो uveitis, that uveitis where there is more pressure. I am not saying uveitis with hypertension, it's a BP problem. No, I am not saying that. I am saying hypertensive uveitis, that uveitis where pressures are very high. This is the crux you have to understand. Posner-Schlossman, very important. If I ask you to note the points, number one, very important, it's primarily a uveitis. Actually, there are recurrent episodes of uveitis, but because the features of uveitis, KPs and all don't seem to be so much and pressures are very high, it is misdiagnosed as angle closure glaucoma. Okay, that is the reason. Sometimes if you look at the case of, see, this is a case of Posner-Schlossman, not very lot of signs seen here. Even the redness in the eye is so mild, and this was a case which has been misdiagnosed as angle closure and already a peripheral iodotomy has been done, but it is not working. Iodectomy hai, not dot. So what is, it is not working for the patient. It should be dotomy only if it has to be done medically, but it looks like, anyway, so whatever. So what I am trying to tell you here is, this was misdiagnosed as angle closure, but this patient continued to having more pressures because the main problem is uveitis. Uveitis may, when there is uveitis, what it is causing, why are the pressures increasing? So the theory says there can be trabeculitis here, okay. So because of inflammation of trabecular meshwork, generally the pressures are increasing and being so high. That is the main exact cause we do not know. It can be HLA associations, it may be CMV infections associations, even H. pylori infection association. Okay, I hope you are noting down the points. So what is the question and what is the answer? Involves marked increase of IOP. Yes, it does. Includes episodic uveitis with photophobia. Yes. Can be associated with H. pylori infection. Yes. Corticosteroids is treatment of choice. No, not exactly. Should we only give corticosteroids, the pressure going to be more high, na? So you will say, and with anti-glaucoma drug, under the anti-glaucoma cover, that is has to be said. So we first start anti-glaucoma, control the pressure. Of course, I will have to give steroids to control uveitis. Continue using anti-glaucoma drug so that the pressures don't increase. So if I ask you the treatment of glaucomatocyclitic crisis or PSS, that is Posner-Schlossman syndrome is PSS, you will say it is steroids but under anti-glaucoma cover. If you are not writing anti-glaucoma drug, this treatment becomes wrong. Okay? So remember this. Okay, we come to this another very important condition, sympathetic ophthalmitis. Before we go to the question, sympathetic ophthalmitis, all of you. First question. It's a type 4 hypersensitivity reaction. What is happening? After perforating injury, in majority of the case, it is the perforating injury in one eye causing uveitis in the other eye. So uveitis of other eye is what is sympathetic. Sympathizing eye mein jo uveitis ho rahi hai, this is why it is happening. It is due to autoimmune reaction to the uveal antigen. Name of the antigen is retinal S if they ask you. So it's not only in the retinal pigmented tissues but also in the uveitis in the uveal tissue. Okay. So retinal S antigen. Yes, Maurice. Okay. It does cause marked increase of pressure, Ravi Shankar. This is the reason for it to be misdiagnosed. Okay. So these are some important points. Then in sympathetic ophthalmitis, they ask you what type of uveitis. You should know it's a granulomatous pan uveitis. This is also a cue. These are all cues. And if it is a granulomatous uveitis, we get nodules, right? And where are the nodules? It is not on the iris. We should know this. This is the retina, this is the choroid, and this is the sclera, right? And this is the anterior segment. Nodules are present between the retina and choroid is Brooks membrane. Innermost layer of the choroid is Brooks membrane. So nodule is present between this Brooks membrane and the retina. This is the Brooks membrane, the dotted line, right? What do we call this? We call this as Dalen-Fuchs nodules. So this is also your exam question. Lot of questions on this topic. Another question, which is the first sign, which is the first symptom. So that we'll come back to here. So first sign, of course, it starts with retrolental flare, all of you. If it starts first sign as retrolental flare, do you realize this is all ciliary body area? What is the prime function of ciliary body here is accommodation. So first symptom cannot be photophobia, this is wrong. It will be difficulty in near vision. Okay, so first it is difficulty in near vision or accommodation. Right, rest all the things are correct. So this is the answer. So that was a very quick revision for sympathetic ophthalmitis. Come to this question now. Thyroid eye disease, identify the odd one. All of you, image question. What do you see here? Of course, I see a lot of chemosis, periocular swelling, proptosis, very much a possibility. What do I see here? I see here a thyroid myopathy where only the tendons are spared and it is only the bulk of the muscle which is involved. Hai na? The belly of the muscle is involved and tendons are spared. So this is again a thyroid eye disease myopathy. Okay, what do we see here? This is a tumor. This is mainly actually rhabdomyosarcoma. So this is the answer of your question. Okay, so this is a tumor in the orbit, which is of course not. So this is not a finding. Here of course this is a finding of thyroid eye disease. Lid retraction. Not only that, upper sclera is also seen, which is staring look. What do you call that? Cocker's sign. We call that Cocker's sign. Yeah, Coca-Cola bottle sign can, yes, that is your thyroid myopathy. Yes. Okay, so this is the answer. If they ask you what is the first or most common finding, you will always say first is always lid retraction. Okay, so initial finding would be lid retraction. Then they have asked you which is the first muscle to be involved. The initial or the first sign, if they ask you, it is generally lid retraction. Lid retraction is called what? Dalrymple sign. Dalrymple sign. Okay, they have asked you which is the first muscle to be involved. What will you answer? First muscle, inferior rectus. If the first muscle is inferior rectus, all of you, what should be the first defective movement? It is not depression, it is fibrosis of muscle. So first defective movement, if they ask you this question, we will answer it is defective. First defective movement is elevation. So there is defective elevation. Okay? Okay? Next question is, which is the last muscle to be involved? It is mainly obliques, and here you will write inferior oblique. Yes, if it is a vertical muscle, it will lead to vertical diplopia, Morris. Okay, so inferior oblique, if you have to choose which oblique. Then they have asked you which part of the muscle involved. It was actually consecutive 3 years they had asked different question on TET. So which part of the muscle? We have just learned it is the belly of the muscle. Right? One very important question. Pay attention and answer. This is for you. You will answer. I will wait. So how do I know that this is a fibrosis and not a palsy? So my question is, this is mainly restrictive myopathy due to fibrosis. What is the test to differentiate restrictive myopathy from paralytic myopathy? Chalo, batao. Very good. Yes. So this is what is, are you asking or are you replying my question? Yes, and then that is your force duction test. Very quickly understand. Force duction test क्या होता है? Force मतलब forcefully, duction means movement. Forcefully movement कराना. So what are we doing here? We ask the patient. So patient has defective elevation. There can be two options. If there is a defective elevation, either the superior rectus is paralyzed or inferior rectus is fibrosed. What you will do? Hold the superior rectus with the forceps. Try to move the eye up. Okay? So when you try to move the eye up with the forceps, it's a forced reduction. So if it goes easily up, it is palsy. But if it is stuck even with the forceps, this is what is fibrosis. So you say forced reduction test is positive. Okay? Yeah. So that will be positive in case of thyroid disease. Come to this one. What do you look at here before we go to which one is all are true related to the condition given below except? What is the condition is this? Everybody recognizes what is this? What are you looking at? This is what is you have learned when there is a floor fracture, blowout fractures, and this is what opacity that you see herniating, this opacity in the maxillary sinus, this is teardrop sign, isn't it? So, this is what is teardrop sign. So, which is the most common, okay, few questions. Most common site of blowout fractures? Most common site for blowout fractures? Blowout fracture is fracture floor. First of all, be very clear, this is fracture floor of orbit is blowout fracture. Most common site is posteromedial. Okay, this is the part is the weakest part, this is important, you should know this. Right, it is the posteromedial part. And of course, the patient, now whenever there is a fracture due to soft tissue reaction, also there can be some restriction of movements. And later, it can be because of what? Muscle getting stuck there, है ना? Entrapment of the muscle. If there is entrapment, which muscles? Inferior muscles, inferior rectus, inferior oblique, generally inferior rectus, commonly. Okay? Okay. Is there any other question related to? Yes. Can you answer me this? Which is the weakest wall of the orbit? Again, this is sometimes wrongly answered. If they ask you weakest wall of orbit, you will not say blowout fracture, you will say medial wall. Okay? Why medial wall? Because of the cribriform plate of ethmoid sinus. That is why we will say it is the weakest wall is always medial. So, do not get confused, weakest wall of the whole orbit is medial, but weakest part of the floor is posteromedial part. Okay? Yeah. Okay, and if the medial wall is also broken, sometimes with the blowout, medial can be broken, it is weakest. Then the ethmoid sinus is opening, so you will get subcutaneous emphysema. Right? Yeah. So, here it is. What is the wrong statement? Chalo padhte hain. Most frequently occurs medial to infraorbital, correct. Associated with hyposthesia of cheek and upper gum is suggesting infraorbital nerve damage. This is correct. Okay, associated with positive force duction test always has extraocular muscles entrapped in the fracture. Not always. It can be soft tissue reaction and hemorrhage which can also cause a positive force duction test in the initial days. Okay, because I will choose this as answer because fourth is also absolutely correct. Kya hai fourth? Associated with medial wall fracture presents with subcutaneous emphysema. Yes. So, our answer here is C. Right. Okay. Maurice, I do not have that slide now. You can ask me individually about it. I will just speak a little bit of that test also. Okay. Then we talk about next is this one. CC fistula was a question even this year. So, that means last PG, carrot CC fistula will lead to what are the findings? Sabse pehle please do not forget the trial. If I am talking about direct fistula is between what? Cavernous sinus and internal carotid artery. Due to the trauma, 75% of the fistulas are formed there. And some meningeal branches, when they are forming the fistula between meningeal branches and the cavernous sinus, this is called indirect. Anyway, in the direct, what is the main triad? Do not forget about pulsating proptosis. Okay? And then what you get is lot of chemosis and whooshing sound on the head, in the head. This is the main whooshing sound in head. This is the main triad for CC fistula that you have to know. So, naturally this will be associated with, okay, what are the features except? It is a pulsating proptosis, diplopia can be there. So, whenever the cavernous sinuses are involved, nerves are involved, you can get all these findings. So, diplopia, yes. More pressures now in the venous drainage is impaired, so venous stasis retinopathy can happen. Then even glaucoma can happen because of increased episcleral venous pressures. What else? Then you can also get ocular ischemias, you will get exophthalmos, you will get diplopia because all 3, 4, 5, 6, everything is passing through the cavernous sinus. So, the nerves will be involved. What is then the answer? Of course, very simple question. It will not be characterized by enophthalmos. Right? Causes of pulsating proptosis. Let us learn this. Pulsating proptosis causes, first is CC fistula, second you will know is whenever the roof is defective and intracerebral pulsations are transmitted to the eye, right. So, when the roof is defective like fracture roof can be one cause or neurofibromatosis type 1. क्या हो रहा है यहाँ पे? Intracerebral pulsations are transmitted to the eye. Which is the most common among all? You will answer most common is CC fistula. This is about pulsating problem. And what is intermittent? Many of you make a mistake. Intermittent means sometimes the eye is normal, sometimes it is proptose. Only cause is varicose veins in the orbit, orbital varices. Okay? So you see, this is a case of bilateral keratoconus fistula with so much of chemosis. And yes, one very important thing, dilated vessels, conjunctival vessels, which can be seen both in direct and indirect. You should be familiar with this. What is this? These are called corkscrew vessels. Okay, these dilatations of vessels, this is a indication of the fistula. These are called corkscrew vessels. Know this. ठीक है, इसको पता होना चाहिए ये चीज. Okay, come to the next one. So this is a patient who is presenting with recurrent chalazion. Histopathological examination should be done to exclude. We all know recurrent chalazion should be suspected for sebaceous cell carcinoma. Which is the most common? Okay, few questions here. Most common malignant tumor of lid? Most common malignant tumor is basal cell carcinoma. And everybody is, what is the commonest? Such a simple topic, but even here there is a commonest mistake. Let me show you something. ये हो गया tarsal plate, ये है lid margin. Simple depiction. Now, and this is your grey line, anterior lid margin, posterior lid margin. Anterior lid margin say these are the lashes. Now, any swelling at the anterior lid margin is hordeolum externum, that is stye. It is painful, so I have made it in red. Again, a painful swelling on the lid, this is called hordeolum. मतलब क्या होता है? Swelling. So, hordeolum internum, this is internum. But if it is a painless swelling, now in the tarsal plate, so this is what is your chalazion. So, what is, both are inflammation in meibomian gland. But this is acute inflammation of meibomian gland. It is called hordeolum internum, and chronic lipogranulomatous inflammation of meibomian gland is chalazion. It's a repeated question, so don't forget, lipogranulomatous inflammation of meibomian gland is your chalazion, right? And do you know, repeated chalazion, you are checking for sebaceous cell, but when there is a recurrent chalazion, first thing that I will ask if the patient comes in my OPD is to get a refraction. When the number is slight and you can manage without the specs, you generally tend not to use the specs. So what you do, you're not even aware of yourself, you keep rubbing the eyes to make the image clear and get the inflammations again and again. So recurrent chalazion, if I talk about most common cause, it is uncorrected mild refractive error. Okay, yeah. So what is this? Is this externum or internum? So it will depend upon if it is painful, but it is mainly on the tarsal plate. This is mainly on the tarsal plate, but this is on the lid margin. So this is a stye. So you should know what is the swelling in the lid margin and which swelling is on the tarsal plate. It has a pus point also. I would just say it is a hordeolum internum here. Acha, yeah, there is one more question on chalazion. What is the treatment? It is generally incision and curettage or incision and drainage. Please answer incision and curettage, not drainage. Okay, it's not a liquid pus, it is mainly organized secretions. So you will answer incision and curettage. Then they will ask you which direction your incision should be. Always vertical. You don't want to damage the ducts of the meibomian glands. So don't make a horizontal, it's a vertical incision when you do an incision and curettage. Okay? Yeah. Okay, so blepharophimosis syndrome is generally associated with all of the following except. Do we remember blepharophimosis syndrome? So what is blepharophimosis syndrome? It's a congenital ptosis with other syndromes, many other features. So what are the features? We have, as you can see, this is when this length is small. The horizontal distance of the lid is small is what is called blepharophimosis, number 1. Okay? You can write it if you want. Second you will see is ptosis, right? Then third feature you will see is congenital ectropion of lower lid, little bit out. Okay, congenital ectropion is rare. This is mainly we learn in relation to blepharophimosis syndrome. Then what else? Can you see the fold of skin here? It is called, normally this fold of skin is epicanthus, but epicanthus, like if you see Japanese, Chinese people, they have small eyes. It is because of that extra fold of skin, but this extra fold of skin is actually arising from upper lid. क्या हो रहा है syndrome में? It is arising from the lower lid. So we call it inversus. So this is actually epicanthus inversus. Okay. And what are the finding? This is telecanthus. I told you telecanthus is far apart medial canthus with normal interpupillary distance. Okay. So these are the features of blepharophimosis syndrome. Right. Now we will solve this question. So what are the features except ectropion? Yes. Epicanthus? Yes. So this is the answer. Sorry. So in all and except, this should be the answer. What is dystichiasis? This has been your exam slide. Dystichiasis is nothing but double row of eyelashes. One is already on the anterior to the grey line. So here this will be a little posterior to the grey line. This double row of eyelashes you have to quickly remove, otherwise it will rub on the cornea and cause damage. Right? So this is your dystichiasis. It's a congenital anomaly. We'll remove it by cryo or try to damage the follicle so that it doesn't grow again and again. Right? Now this was again, I have taken it as such because this has been asked in this PG. So you should know what is this. What is the spot diagnosis? Adhesion between the two lids. Right? This is what is called ankyloblepharon. You know what is ectropion, outward turning. You know trichiasis is misdirection of eyelash. And what is symblepharon? Adhesion of bulbar conjunctiva with palpebral conjunctiva. This is what is symblepharon. Maybe this next time they ask you this. It can be due to ulcers, all types of burns, chemical injuries. It's a scarring. Okay. This is symblepharon. Yes, very nicely answering, very good. So epilation, Morris, if you keep doing it again and again, so it's instead you can go for damaging it in a permanent way. Yeah. Okay. Okay, so this was the this is what is your mild entropion with trichiasis, which is misdirection of eyelash. Right? Yeah. So talking about Hess chart, they have not asked you anything much, Morris, except that okay, what is it? So look at that, this is a Hess chart, right? So understand the Hess chart, you will have to understand about the muscles, and if you are very thorough with the yoke muscles and all, you will know how to label that muscles, right? Now in the Hess charting, it is mainly based on foveal projection. Whatever the patient is seeing, you are charting it like this. So what you do is, again you are wearing a red-green goggles. This time you can change the red and the green. So the red color is mainly for fixation, means agar ye chart, if there is a screen or chart in front of the patient, he is wearing a red-green. This time the red is in his right eye. Then I am charting green in the left, means I am charting the green eye first. If the green is on the right side, I am charting the right eye. So wherever the green is. So I will show, or maybe it is automatic, there are red points. He has to overlap the red points with his green points. Right? So where he can see. And this will very clearly depict which muscle is underacting, which muscle is overacting. Okay, so it is made up of mainly squares, right? So every square is 5 degrees. So either we take a 15-degree square or bada wala 30-degree square, and then we test it. So in overaction, so if you will see 1 or 2 slides, you will know. You will just look at my lectures, you will know what is Hess chart, and that won't be difficult. And I don't think so they are going to ask you in detail about it. The only question in so many years, I have been teaching you all since I have told you how many years. I have seen only one single question where they have just put it and said, what is it? And you had to answer, okay, this is Hess chart. So Hess chart is mainly going to tell us about which muscle is overacting, which muscle is underacting. And whenever there is a palsy, there is a sequelae that happens. So that sequelae is depicted in this. Okay. So that was all. Thank you, and any questions that you have, you can contact me one-on-one, and I will solve your questions and message you. I may be a little late here and there, but I make it a point that I definitely, I shouldn't be missing it, and I should be able to solve all your queries. Okay? Thank you so much. All the best, all of you. Be fighters. Keep running your own race. Okay, and be very focused. Don't self-pity yourself. You have still a lot of time to socho ek din mein how many hours, how many minutes, so you can really fight hard and hard. Just run your own race, make a smart schedule and focus, and keep revising. Okay. And so you have to remember this, that it is a tough people, it is a tough times don't last, but tough people do, right? So you have to be just a little tough. And of course you will feel like complaining, you are going to feel like sulking, but you don't have any option. Don't do that. Just appreciate wherever you are and keep running your own race. So thank you so much. Stay blessed and keep smiling. Thank you.